So I would like to first thank you, Dr. Shen Hong and Hong Kong Health Authority for an opportunity to participate in this wonderful meeting. And my assignment today pertaining to the topic of containing COVID-19 in Thailand. And I would like to share with you the successful story that we have in Thailand. The objective over the next 30 minutes will include first, I would like to share with you the past experience on emerging infectious disease containment in Thailand to set the tone for the COVID containment in Thailand. And then I would like to share with you the epidemiology of COVID-19 in Thailand, as well as the public health policy for containing COVID-19 in Thailand, as well as the hospital infection prevention in Thailand. First, I would like to start by saying that SARS is a well-known pathogen, and you are all in Hong Kong know well about SARS that has been spreading in Hong Kong around year 2002. This is one of the favorite PowerPoint about SARS, and the message that people like to say is that SARS emerging from Hotel M in Hong Kong and spread throughout the world, and a lot of country has affected the secondary chain transmission of SARS as shown in these pictures. But what I would like to say is that in Thailand is quite opposite, because Thailand is the only country in the world that did not have the secondary chain of transmission among the healthcare worker in Thailand at all, unlike other countries. Why? Because Thailand have infection control and get used to infection control at that time? Probably not. I have contributed all the successful containment at that time to this single person, that is Dr. Carlo, who has been passed away in Thailand. He worked for WHO and has been submitted from WHO to Vietnam to help establish infection control in Vietnam. Unfortunately, Dr. Carlo gets sick and he requested to be treated in Thailand. And upon getting to the airport in Thailand, he asked the hospital to specifically pick him up from the airport and prepare everything ready for him. At that time, you can imagine that negative pressure unit is very rare to have in Thailand. And this hospital that is now we call at BD Hospital, that stand for Bamlat Naradun Hospital, is now the institution for emerging infectious disease. At that time that Dr. Carlo come to Thailand, they are not ready to host Dr. Carlo at all. They don't have even a single negative pressure unit, but they modify the isolation room to be the unit that hosting Dr. Carlo. And you can see here, this is the unit that they design, and they design a simple unit divided into sections to make it less cross-contamination when hosting Dr. Carlo in the room. In addition, they also monitor the practice, including the compliance with the basic infection control measure, including the done and doff PPE, making a good education. And as you can see here, a lot of process has been monitored with a very, very high compliance to the PPE use, as well as the hand hygiene as well. And as a result, there's no single case of healthcare worker get infected with SARS during Dr. Carlo visit in Thailand, and he passed away in Thailand and leave his legacy in his by his name in Thailand, that we are in good shape because of him. So with that, BD has been designed as the emerging infectious disease hospital in Thailand, and we have a lot of progress over the time. And in year 2012, the incident of MERS occurs, and we have the MERS in Thailand as well. But Thailand, again, is the only country in the world that did not have any document secondary chain of transmission among healthcare workers at all. And this is the document of the zero transmission of MERS in Thailand that has been written clearly in CID around year 2015. Comparing with the experience from SARS, MERS occurred approximately 12 years later than SARS, and at that time, the BD hospital are well equipped with a lot of things, including molecular method to detect the emerging infectious disease. They have at least 5 negative pressure units at that time. They have plenty of PPE and N95 mask supply at that time. They have a lot of protocol implementing, including environmental cleaning procedure, infectious disease waste management, and also business continuity plan that has been built during MERS comparing to SARS. And as a result, we don't have any secondary chain of transmission of MERS in Thailand comparing to many other countries that has been severely affected by secondary chain of transmission. So I'm saying that because I want to build upon the successful containment of COVID-19 in Thailand. And I would like to share with you, I know a lot of Hong Kong people went to Thailand for shopping. And Thailand is very famous for not only shopping, we also have a lot of neighborhood traveling around the border. And we are in Southeast Asia. And of course, a lot of Burmese people, a lot of Lao people came here working in Thailand, and this also can be a source of dissemination of emerging infectious disease from the border as well. The first case of COVID-19 in Thailand occurred after the incident of outbreak of COVID that occurring in China. And as you can see here, the case in January start a little bit, and majority of the cases has been imported from China, with a very few locally transmitted case detected in Thailand. The recommendation and advice for the public health at that time, including the basic principle to reduce the risk of transmission, including the suggestion to avoid close contact with people suffering from acute respiratory infection, with the suggestion to do a frequent hand washing, particularly after direct contact with ill people or the environment. And the suggestion is also extending to avoid unprotected contact with the farm or wild animals, and people with symptoms of acute respiratory infection should practice cough etiquette, which has been defined clearly in the parentheses. Within the healthcare facility, the enhanced standard infection prevention and control practices are recommended in many places, especially in the emergency department unit. This is the virus tracker, and as you can see here, Hong Kong has more cases than Thailand at that time. And at that time, Hong Kong had 56 cases, and Thailand has 34 cases. And majority of cases came from the high-risk country, including China, Hong Kong, Taiwan, Japan, Singapore, and South Korea, where the advice for returning from those at-risk countries, including 14-day self-quarantine, no contact with the public, no public transportation service, wearing a face mask, and when showing symptoms, you should go to the nearest hospital immediately and ask the patient to tell the truth. Also, the big incident start from March, where there are some incident going on. First, the case from boxing stadium and entertainment venue has been jacking up because boxing is a very good place where you can disseminate the infection, because they yell, they are close together at a very close tight hall that containing 10,000 people. And after that, we start to detect a lot more cases. And after that, we have the incident of people that came back from Dawa pilgrimage, together with the changing in the testing that we only require one positive result for confirmation of COVID-19 instead of two results to confirm it. So the analysis of the situation at that time is that we changing the laboratory policy together with the incident at the boxing stadium really disseminated the case up to almost 1,000 within a month. And recommendation and advice for public at that time, including to remain inside your home, leaving your home only for essential activities, and always try to maintain a distant social distancing, as you all know, and wash hands frequently with alcohol, and do not touch your eye, nose, and mouth. And if you are unwell, wearing a mask, and do not use N95 masks. We recommend this to the public because this should be used by the healthcare workers. And the cough or sneeze into your elbow or a clean tissue, and practice the cough etiquette, and do not shake hands, embrace. And in Thai culture, we use sawadi as a mean for greeting. We don't shake hands, we don't embrace, which is a good thing. And keep our commonly touched surface clean. And advice on cleaning practice and the survivability of the SARS or coronavirus on the surface with different settings are available in many places as well. In terms of molecular epidemiology in Thailand, we start with the S strain, which came from Thailand, from European country, America, and Australia. And then the genotype has been changing to L type, which is more likely to be contagious, and also has been shown to be more virulent as well, and has been spread from European and America and going to Thailand. And also now the gene has mutated to be the G type and V type that came from European country, Australia, and some American as well. So the public health policy that we implement in Thailand at that time, including first, we start to lock down the country after we have cases up to 3,000 in March. The government invoked emergency decree from March to early May, and National Command Center called COVID-19 has been opened with the way to standardize surveillance, case detection, risk assessment, laboratory diagnosis, clinical management, and hospital infection control and clinical guidelines as well. This is what the national policy do. What I think is quite unique for the public policy is that we are the very first country in the world that I can call that we use the universal masking in all the public places at the very beginning of epidemic, similar to other Asian countries. And this is contrast to what European people do because they don't believe in the concept of universal masking. What we do is very quickly, and all the patients with a very mild illness had to be reported per the government and admitted to the hospital until the culture turned out negative. And we also opened the field hospital to accept all cases that get well clinically, but PCR still positive for COVID until the PCR turned negative to alleviate the hospital admission burden of COVID-19 cases. And this is a quite unique policy that I think can help limit transmission in the public and also limit the transmission among people who have asymptomatic or pre-symptomatic to get spread and also to contain the spread at home as well. This is the photo in the public that people strictly follow the universal masking in Thailand. And this is many places that we monitor, they are all comply with the universal masking policy. And as you can see here, it's very obvious Western people don't follow the universal masking policy, but Thai people do very religiously, and they're really afraid of COVID themselves. We also have mechanism to screen people at the border, particularly the worker that came back from the border country, like Myanmar and Laos need to be screened and comply with the government policy. And my hospital also opened the field hospital to accept the patient with COVID who already get treated and are not ready to go back home because at that time either the home are not willing to accept him or PCR still positive less than 10 days. So they had to be stay at the field hospital until the readiness of the status at home and PCR turned out to be negative at that time to let him or patient go home. So to analyze this situation, the successful containment happened because people are under emergency decree that mandate sick people, even with a mild symptom to be admitted. And we have a national government that have enforced a nationwide curfew, and the Thai culture, I think, play an important role because people usually obey and respect and follow the law, unlike many Western countries that they are very liberal and may think that freedom is the first priority. But Thai people obey the law and follow the rule set by the government. And we also have the standardized policy throughout the country. And this again, unlike other countries, particularly I can give an example of US that many states have their own policy, but Thailand has only one command center that can be easily centralize the policy and make it easy to follow the same policy in all 73 provinces in Thailand. We have like approximately 65 million people in 73 provinces in Thailand. One thing that the government follow upon is the strategy called the hammer and the dance, where the hammer is the phase that if you have a lot of case, the government start to lock down and get the proper testing, tracking, and have testing those who are at risk for COVID and on the dance state. Once the replication capacity has been below 1, the government will loosening a lot of lockdown places, and they are gradually loosening places in phases. And this has been working well for us in Thailand and leading to less public transmission of COVID-19 in Thailand. As a result, this is posted in newspaper every day. This is the number of cases today is 1, and majority of the case that detect every day now came from the state quarantine, which means that people came back from other country and they want to work in Thailand, and they come back to Thailand, they have to be quarantined. And today, for example, is 1 case, and we have accumulation cases of 3,000 a little bit cases, with the mortality has been detected up to 58 people or less than 2%. This is a very decent number in my view. For the hospital infection prevention policy, there is a standardized national guideline for the treatment and control for COVID-19. For example, my hospital, there will be 2 negative pressure unit only with 1 cohort unit that was modified to host the COVID-19. We also developed a system to screen the index case, the case under investigation, and the healthcare worker, and develop admission pathway from emergency department and referral center as well. The hospital will start at the morning, every morning at the war room to discuss the daily issue for COVID-19 in terms of conflict that may happen and the management that will be introduced, as well as the strategy to improve the supply, reuse the PPE. At that time, there are a lot of donation. A lot of Thai food is available in the afternoon and at night for the doctor as well. And we open the communication pathway by social media, including the Line app for a lot of discipline like the ID, ER, IC, and medicine pediatric discipline. And also we training healthcare worker to don and doff PPE, washing hand, and also have adequate laboratory collection. We also continuously educate healthcare worker for COVID knowledge and monitor system for at-risk contact during work. For the initial phase, the Thai NIH are responsible for accepting all the lab to test for COVID, and they test it for free for all the country. But later on, we developed the in-house PCR to make it quicker for reporting the lab immediately. So also we work with the field hospital to facilitate patient discharge plan as well. I would have to say that what I think is unique is the policy that we are also a very first country in the world that use universal masking among healthcare workers early on in the epidemic. While the US, there are some debate about the pro and con, we accept it. And also the social distancing is very well followed in many places, including the restaurant, at the workplace, and also hand hygiene adherence is sky high with availability of alcohol in all hospital places. And also we are monitoring healthcare worker and ask them to have a self-report in many units who are at risk for COVID contraction. Of course, now there are accumulating evidence suggesting that the face mask against COVID, even in the community, can help reduce the transmission of COVID significantly. If the US adopt this policy early on and increase the face mask by 15%, they would be able to stop locking down effectively and also cut down more significantly the transmission in the public. That is according the recent data that we have. Also, there are more accumulating data suggesting that using universal masks in the hospital has been associated with a large reduction in the risk of the COVID transmission reduction. So this clearly has been sharing and accumulating benefit from universal masking policy that we adopted at that time without this evidence come out. This is the example of the national guideline for the screening, the definition for surveillance, and also the treatment and of the case with asymptomatic, mild case, and severe case. And this has been issued and updated every 2 weeks by the Thai government. This is the photo of myself when I going to see the COVID patients, and also this is the housekeepers. They have to wear this suit going to the cohort area that was modified to accept the COVID patient in here. We also come up with the strategy to investigate the first chain, the second chain, and the third chain of contact to the COVID patient. And what we recommended is that for the first chain of contact, they should do strictly home quarantine, while the secondary chain and third chain contact, they should do self-monitoring for any symptom and avoid contact, and going to public place is not necessary. The present surprise at that time, in my view, is that there are a lot of donation. And the example of donation, including a lot of PPE, a lot of negative pressure unit fund that came from the government. For example, my hospital got a fund from the government for 15 beds that immediately built very quickly. And also we have a lot of food. As you know, Thai food is very good, and we enjoy a lot of lunch and dinner. A lot of donation from the owner of 7-Eleven in Thailand. And also we have a good equipment to use, even though the evidence are quite limited, is the UV light and ozone machine for COVID. And also we have the new laboratory section for emerging infectious disease that was well budgeted from the government, and the budget for the lab, any rapid test for COVID has been donated from China. We got it, and also any IT, including the robot to dispense medication, is also offered at some hospital as well. Having said that, I foresee a lot of opportunities for improvement, and these include mechanism to deal with emotion is still not there yet, because there are a lot of panic, fear, anxiety among healthcare workers, and the standard of care are compromised in many places, including no laboratory collection done at ER, no antibiotic given at ER, which really compromise the safety of the patient care. That makes us, the ID doctor, are very worried about it. And also the communication skill between healthcare worker in different specialty is still need to be improved, including the interaction between the lab, treating physician, and ID doctor. And I would have to say this happened because they are fear that the section will get COVID. For example, if the lab are very fear of COVID, they will not comply with what we want them to do. So the lack of communication is one of the things that I think we have to move on. That is why I show the following slide, because this is the slide that came out early on in New England Journal. And the message here is that to remind the doctor to the reason rather than follow the emotion. I can give you the example. They give a very clear example. They say that the doctor say the patient has 3 negative tests for coronavirus, but I don't care. I'm sure that he had COVID. So, and why you do the test for? You don't follow the scientific. The second doctor saying that he see the patient with chest pain doing the EKG and saw reduced ejection fraction. And despite the focal ECG abnormality and history of coronary artery disease, the doctor declined, saying that he probably have COVID-related cardiomyopathy. So what does this represent? It represents that doctors are trained as scientists and expected to follow a hypothesis-driven, rational, and evidence-based approach to clinical decision-making. But doctors can be swayed by stories that under the pressure during the crisis. Having causing harm is not common during crisis, and the example is pretty clear. At the time of SARS in year 2003, at that time people used ribavirin, which has no evidence support by RCT treating the SARS patient. And at that time, ribavirin causing a lot of hemolytic anemia of the patient. So this could be very harmful without the evidence of effectiveness. And this remind us to the reason rather than emotion. Of course, anxiety and fear of contagious, despite the evidence of PPE use is effective, may be alter the care, and clinicians have to be infected with COVID. It is often unclear whether the infection was attributed to work exposure or contact outside the hospital. So clearly, we really have to follow the scientific, and we must rely on the scientific, particularly the effectiveness of PPE in preventing them of contracting the disease. And I like this article because they've written clearly that we are living through an unprecedented biopsychological crisis, and physicians must be the voice of reason and must lead by example. We must reason critically and reflect on the bias that may influence our thinking process. Critically apply the evidence in deciding how to treat patients and use anecdotal only to generate hypotheses for clinical trial. And this is very clear article that I see during COVID as well. This is why we performed the study, and the study published in ISHI just a few months ago. And the message is that we would like to test the emotion of the healthcare worker, whether or not during the COVID they have anxiety, fear or not, and what is the impact of anxiety and fear toward infection control practice among the healthcare worker. And the messages that we got is pretty clear that the confidence, despite having very high on the hospital preparedness for COVID-19, but majority of healthcare workers, up to 90% or more, are anxiety and fear of COVID. But the positive spin is that the practice of infection control is sky high, They're washing hand a lot, they're wearing masks a lot, and they do a lot of social distancing. But the complaint that they have is that they would like the hospital to supply more PPE and also giving them a lot of ongoing education on transmission of disease, and some really ask for some mindfulness practice because they are in stress during the COVID situation. We also perform analysis, and clearly the fear and anxiety, healthcare workers were more likely to wash hands and wear masks and PPE, that they were less likely to willing to see admitted patient and accept the new admission during epidemic, which is the downside of the emotion that occur that may compromise the patient safety in our country. We do a follow-up work and to review the psychological impact and the strategy to deal with this impact and with this psychological things that occur during COVID. And as you can see here, a lot of country like Chinese country, they are affected by a lot of emotion, not only fear, anxiety, some also including depression, stress disorder, sleep disorder as well, while the risk factor is clearly related to female or those who have direct contact or those who are the frontline healthcare worker have a higher risk for this emotion than those who did not see the patient. Of course, the strategy to deal with this emotion will require a lot of fraction, including the team leader, the IPC, and also the healthcare worker and the colleague, and also the community, and the strategy including from the team leader, including the national guideline for clinical care for IPC and a clear communication and staff and accept coping differences and administration team to deal with the healthcare worker prevention and appropriate chip for the healthcare worker. For the IPC team, we need to enforce the IPC measure and regular train with focus on how disease transmission and prevention do occur. And we need to standardize the national training for disease understanding done enough PPE with a clear direction and enforcement with IPC procedure. Also, for healthcare worker, colleague, and community, they need any strategy to facilitate staff. For example, a video facilitate staff to keep contact with the family, and also some alternative accommodation for staff who are concerned about infecting their family, and guarantee food and daily living supply, and attention to media portrayal of healthcare worker, and rely on trusted resource and minimize stigmatization of the disease among healthcare workers if they got infected. And these are the strategy that we review in the literature, both in Chinese and non-Chinese literature that published during the past few months. Also, we do the study, look at the patient population, and I would like to focus on the emotion of anxiety, fear, and panic. Likewise, the patient also fear, overwhelmed with anxiety, fear, and panic for COVID epidemic. Despite a very high confidence in infection prevention practices that we implement in the hospital, they are still in fear. But the positive spin of the fear among the patient is that they are practicing hand hygiene, wearing a mask, and doing a physical distancing more than COVID. And also, really, the negative spin has been showing that they feel stigmatization is very strong about the patient that infected with COVID. Sometimes the violence can occur if stigmatization do occur. Does any education that provided to the patient need to take into account the mechanism of transmission and the strategy to minimize the stigmatization of the COVID patient as well? Of note, a lot of patients still use inappropriate masks. For example, N95 masks and some surgical masks that used in healthcare was used by the patient population as well, and these are not recommended in Thailand. We suggest them to use the cloth mask in Thailand. Again, I would like to share with you that the situation of COVID in Thailand is fairly good, and we are now don't have the in-country transmission of COVID for at least 2 or 3 months. And the case today, as I show you previously, is only one, and sometimes zero. And the accumulated case is total up to 3,000 something, with the mortality is less than 2%. This is considered a big success for 65 million people country with 72 provinces in Thailand. To analyze the success that I mentioned, I think there are a lot of combination of things that we do that make it success, including the national policy that admit all cases, even the patient had mild symptom at the early on into epidemic, really help limit the transmission of pre-symptomatic and asymptomatic cases. And also the universal masking policy in the public and in the hospital really do the magic. And also the discharge policy for the patient also require PCR to be negative early on into epidemic that may limit transmission at home. And at this point, it is now a little bit controversy, given that we know that after 10 days, the pathogen may be a dead pathogen, so there's no need to be repeat the PCR anymore. And also the transition of patient before discharge to the field hospital will help slow down the transmission at home to the at-risk people at home. And also I think I'm thankful to the Thai culture that people don't hug, don't embrace, they use shake hand. They don't shake hand, they use sawadee as a mean to greeting. And also Thai people are very obey to the law and they listen to the government very religiously. So these are all the key for the success analysis. And with that, I would like to again thank you, Hong Kong Health Authority, for a kind invitation to join this meeting, and also Dr. Chen Hong, and also my good friend Dr. Wong for a kind invitation to be here. Thank you very much for your attention. ขอบคุณครับ